Welcome to Healthcare Blind Spots. I'm Vivian Kopsinger-Birchall, and my special guest is Dr. Jerome. Doctor, welcome to the show.
Thank you, Vivian. It's good to be here with you.
It's good to be here. And to our viewers, Dr. Jerome Waye is a retired endoscopist. He retired 4 years ago from active practice at Mount Sinai Hospital in New York. He began private practice in 1963 and is a professor emeritus both in medicine and surgery at the I think I will let him tell us what the right pronunciation of that medical school is at Mount Sinai. He also developed many techniques in colonoscopy and has been one of the best known teachers of endoscopy, having participated in many live courses throughout the world. And while in private practice, he published over 200 papers and authored 7 books, including the award-winning classic Colonoscopy, Principles and Practice. He was one of the co-founders of the New York Society of Gastroenterology and Endoscopy and has been the president of the American Society for Gastrointestinal Endoscopy and president of the American College of Gastroenterology and president of the World Endoscopy Organization. He's currently successfully training endoscopists in Uganda via Zoom, and we'll talk about that, inaugurating the first program to teach endoscopy remotely. I'm so excited to have you here, Dr. Waye. And with his permission, he's asked me to call him Jerry. Jerry and I both serve on the board of AFREC, which is the African Esophageal Cancer Consortium Foundation. And it's so exciting to have you to tell us more about endoscopy. And the first question I have for you, doctor, is what drew you personally to the field of endoscopy? And then we'll take it from there.
Well, I began endoscopy at Mount Sinai when I was in fellowship there, a fellowship in gastroenterology back in 1960s, early 1960s. I graduated from medical school in 1954, rather, I graduated from MIT in 1954, and I graduated from medical school in 1958. I went straight to Mount Sinai and took my rotating internship, residency in internal medicine, and then fellowship in gastroenterology. I finished in 1963. Interestingly enough, when I was in my fellowship, the whole idea of flexible instruments came into view. We were using rigid instruments up until that time. They were really absolutely rigid, like a lead pipe. And we would put those down patients' throats, and it was really very difficult. And as far as looking in the colon was concerned, we only had a tube that was about 10 inches long. And it was a rigid tube, and that's all we could intubate into the lower rectum. So when flexible instrumentation came about, I was in my fellowship, and we were being taught rigid endoscopy on Tuesdays by one doctor and Thursdays by another doctor. So when the flexible instruments came out, I learned from one doctor on Tuesday. We were stumbling through how to do it together, and another doctor on Thursday. When I finished my fellowship, I had twice as much experience with the flexible instruments as either one of those. So I was asked to be the teacher for flexible endoscopy, which they thought was going to disappear. But in reality, it was such a fascinating and innovative approach to endoscopy that within 3 years they disappeared. And I became the very young director of endoscopy because I was much more familiar with flexible instruments. So when I went into private practice, I went into private practice with flexible endoscopy, and colonoscopy was just really getting started in the United States. So I was one of the first people to do colonoscopy in the United States, and that is the only way we could look in the colon before was with this rigid 10-inch instrument. So when colonoscopy came around, I was able to use my skills in flexible endoscopy to do colonoscopy, and colonoscopy really took off, and I was one of the leaders in developing colonoscopy. Actually, it was sort of an accident that that I learned how to do colonoscopy, because when colonoscopy started, the only way we could tell where the instrument was by using fluoroscopy. And so the first day that I was going to do colonoscopy, I did it in the X-ray department. And in the X-ray department, the director, with whom I was quite friendly, let me have an endoscopy, have a fluoroscopy room to do endoscopy. Well, that day, the room was crowded with the director of radiology and his senior staff, the director of gastroenterology and our senior staff, because everyone wanted to see how colonoscopy was going to be done. So after the first hour, all the senior people left. After the second hour, all the fellows left. After the third hour, I couldn't even find an X-ray technician, but I was still doing that same colonoscopy. And so the director of radiology called me in the next day and said, Jerry, you can't use my radiology department anymore, because we were doing barium enemas, and they were doing lots of barium enemas to look at the colon. And he said, we could have done 10 barium enemas while you were still doing that colonoscopy. So you can't use my department anymore. So then I had to figure out what to do, because if I couldn't use fluoroscopy, I couldn't do colonoscopy. So I figured out ways of doing colonoscopy without fluoroscopy, and that's really what started the whole trend to make colonoscopy much more accessible, because I was able to discover ways of knowing where we were in the colon without using fluoroscopy, and that sort of gave the impetus for more people to be able to do colonoscopy. So that's how I started in colonoscopy, and that was my beginning in the whole area of flexible endoscopy, colonoscopy, and now it's one of the things that people take for granted, that we can use flexible instruments to look in the esophagus, stomach, and upper intestinal tract, and also flexible instruments to do colonoscopy. So that's how I got started, and I've been doing it ever since.
What a story, what a journey, and you brought an inspiration to, to hear the stories of how this all began, especially in the United States, which is the center of science and innovation and medicine. So and to be here speaking to one of the pioneers in the field, I feel honored and quite blessed. But you've also mentioned, you talked about things that I was going to ask later, the evolution of the techniques. But I will get into that later. But maybe still on the same subject, can you walk us through what endoscopy is and how it helps the doctors to see to see and treat what's happening inside the body without surgery?
Sure. Endoscopy really is a term that uses endo for one, which means inside, and oscopy, which is a tool to look into, like microscopy, or any of the ways we can look inside the human body. So endoscopy really means anything that we can look, a tool to look inside the body. And so it can be bronchoscopy to look in the lungs, or colposcopy for GYN purposes, and endoscopy for us really means either upper endoscopy, which is gastroscopy, or lower endoscopy, which is colonoscopy. So we look inside the body with these instruments. Now, the flexible instruments are interesting. When we first started flexible endoscopy, the image was transmitted by lots of little glass fibers that were aligned, and you could see what was going on in the intestinal tract by transmission from these glass fibers. But now we have small video chips on the end of the instruments, and the video chips are tiny. They're maybe the size of the head of a pin. And that video chip allows us to do a broadcast from inside the body to through the electronics into a big screen. So we no longer have to hold the instrument up to our eye and look like we had to with fiber optics. We can now transmit it to a big television screen. And in fact, we usually have multiple television screens throughout the room when we're doing endoscopy so that others can watch and assist in the procedure itself. So now we have flexible endoscopy that's all video based. Not only can we deploy it in the endoscopy room, but we can transmit it across the nations. And in fact, right now, there's a course going on in Kenya that we can tap into here in the United States and watch what they're doing in the workshop right now in Africa. So it's a great use of technology. We can Zoom anywhere, or use Zoom or use any of the transmission platforms that are currently available. We've moved endoscopy from an individual one-on-one performance so that the whole world can participate in what we're doing and watch and learn from us doing endoscopy.
Which is a great segue into my next question. You're kind of preempting my questions, which is great. But it's what are some of the more groundbreaking innovations in endoscopy over the past decade? That and how have they improved this patient care? I know you've touched about your ability now to train endoscopists in other regions, but is there any particular innovations that you would consider groundbreaking?
Yes, I think that a few years ago, um, I went to Uganda at the request of the chief of surgery at Mount Sinai, who actually built an endoscopy or a surgical unit in Uganda. He wanted me to introduce endoscopy to the surgical unit. And he had been asking me for 2 years to do that. And I told him I couldn't, I just didn't have the time to do it. But um, I was going to go to Addis Ababa to train doctors in endoscopy. So since I was going to Addis, I suggested to the chief of endoscopy I could go to Uganda when I was finished with my training in Addis and go to Uganda and teach. So we set up a unit where I was able to teach 6 surgeons how to do endoscopy. You really can't teach endoscopy in a week. In the United States, the fellows take 3 years to learn how to do endoscopy. So in a week, I could just teach them what the instrument was about, how to use it, what to do with it, how to be safe in its use. And when I left, the each of the 6 surgeons I was able to have do one upper endoscopy and one colonoscopy under my supervision.
Hmm.
So when I got back, the chief of surgery asked me if I could continue to teach, although I was back in the United States. So I said, gee, I don't think we can do that. That's hasn't been done before. You have to be right beside the person that that you're teaching. So he said, well, we've set up a special unit where we can transmit a view of the operator's hands and a view through the scope so that you can see back in New York exactly what's happening in Uganda. I said, I can give it a try, but it's never been done before. So I gave it a try, and actually, I was surprised at how efficient it was because the transmission is instantaneous. I can see exactly what the operator's doing with their hands. I can see what scope is seeing inside the body, just as if I were beside them in the endoscopy suite at Sinai. So the important thing was we had instantaneous communication. I could say, give a little bit of air, and they would give a little bit of air, just like if I were beside the student in the endoscopy room. I would say, pull back a little bit here or twist the scope to the right, and they would instantaneously respond. Well, I was surprised at how remarkable this tool was that we could actually train someone how to do endoscopy remotely. So I trained this Dr. Joseph Demoy Okello, who was at the Cuavira Surgical Center that had been built by Dr. Marin, and we took him through basic endoscopy. In United States, we're beside the student all the time. In fact, until for the whole 3 years of the student learning not only endoscopy, but they learn gastroenterology and inflammatory bowel diseases and liver disease and everything else. So endoscopy is something that's woven into their course schedule for 3 years. When they do endoscopy, they are never, ever alone. They're always monitored by someone. And the first time they do something of their own is when they've finished their training and they go out and practice. So I was able to bring Dr. Joseph from the 1 week where he just became familiar with how to hold the instrument and how to twist it and that sort of thing. I was able to take him through actual upper endoscopies one-on-one and taught him how to intubate it into the esophagus, what he was looking at, because the things that he was seeing in the stomach they'd never seen before. So I had to explain to him, this fold is this means this, and this color means that, and this little dot is we don't have to worry about, but this dot we do have to worry about. And so we were able to together explore the whole area of learning through remote training. So we got Dr. Joseph to be able to do upper endoscopy and colonoscopy, and he now does excellent procedures. He is a qualified, absolutely remarkable endoscopist now, and he is now training others to do endoscopy. So it's wonderful to be able to do this remote training, and it's a whole new paradigm in the field of endoscopy. So we're starting to do that now. We're looking to try to find low cost equipment that can be used in Africa or throughout the world, because in low resource countries, they need low cost equipment. So right now, the instruments we're using cost maybe $4,000 for the setup that's in Uganda. For me, I don't need anything special except my television, my Mac at home, and I can tune into anybody that does remote endoscopy throughout the world. So it's a whole new way of learning and teaching and being able to progress the field of endoscopy.
First of all, as a Ugandan immigrant, I am eternally grateful for that service that you have provided and continue to provide for our country, people, because again, like you mentioned, if you had doctors like Dr. Joseph, who had never seen the inside of a human, and yet many patients depend on this healthcare system. I think what is being done here is building capacity locally, and there's a lot of value that comes with that, and especially since he's now a trainer of train, he's training others. So thank you for that vision and for your dedication to it. That and you talked about the low cost, solutions that we need. Maybe in terms now using even Uganda as an example, what are some of those low cost solutions that you would, you know, that can be deployed in such settings, not just for Uganda, but other low resource settings in Africa or the world?
Actually, it's quite remarkable that in low resource countries, uh, patients uh, really don't have access to endoscopy. Here in the United States, uh, we don't think of anything. Putting the scope down, looking at somebody's stomach, if they have abdominal pain. Patients expect it, and we certainly are used to looking inside the body and finding out what's wrong directly. We used to use x-rays for all this, but now endoscopy has taken over the ability to actually look inside the body, inside the intestinal tract. So in low resource areas throughout the world, patients don't have that. Patients come in with abdominal pain, and doctors sort of treat them um, symptomatically because they don't really know what's going on inside the body. They don't have access to x-rays, and they certainly don't have access to endoscopy. So the advent of having the use of endoscopy to look inside the body has made a tremendous amount of difference. Um, for example, if patients come in with difficulty swallowing, um, in uh, in the southeastern part of Africa, esophageal cancer is quite common. In fact, it's the third most common cancer in this area of the world. So when patients come in with difficulty swallowing, the first thing you think of is that they have esophageal cancer. However, we have found by doing endoscopy in the Kiuvira Surgical Center, we have found that half of the people that present with difficulty swallowing don't have esophageal cancer. They may have other problems. They may have a web or a stricture, a narrowing of the esophagus due to other things, or a dysfunction of the esophagus. There is something called achalasia, where the esophagus, the lower end of the esophagus, doesn't open properly and causes patients to have difficulty swallowing. And so there's lots and lots of other causes. So it's nice to be able to tell a patient that you look down and there is no cancer of the esophagus, but they have something else that can be treated, and they don't have to worry that they're going to die of esophageal cancer.
Right. How does this, it's great that you touch about the kind of early detection that and prognosis that goes on with the use of the endoscopy or endoscopic instruments. So how does this early detection through the endoscopy change the prognosis of diseases like esophageal cancer, colorectal cancer, and um, and also when you mentioned about the cancer of esophageal cancer, there is not much distinction between that and the cancer of the thorax. Um, I forget the name, the right name of the cancer. But what cancers affect that the throat and neck area that oftentimes people get confused?
There's pharyngeal cancer, and there's lung cancer, and there's esophageal cancer. there's a lot of different cancers that occur in the upper part of the body, and the distinction between cancer of the mouth and pharynx and esophagus are quite different. If one has cancer of the throat or the pharynx area, it's usually quite difficult to access that, and patients may need a removal of the pharynx and larynx. They may not be able to speak, but they may have a hole in the middle of their throat to be able to breathe. So this cancer is a different cancer than cancer of the esophagus, which is actually in the swallowing tube itself. In the United States, most cancers of the esophagus are a certain type of cancer called adenocarcinoma, and it's usually close to the stomach area. And this is a cancer that comes from chronic irritation in the lower esophagus due to reflux, due to acid, due to multiple factors. But in the United States, the cancer of adenocarcinoma low down in the lower part of the esophagus, just before the stomach, is the common type of cancer. In this part of Africa, in the southeastern portion of Africa, the cancers of the esophagus that occur with high frequency are called squamous cell cancers, and they're a different cancer. They occur maybe in younger people. They occur from lots of other factors than reflux. And this type of cancer is quite common in this southeastern part of Africa. In fact, there are a few belts of cancer, of squamous cell cancer that that occur throughout the world. In the rest of the world, squamous cell cancer is the most common cancer of the esophagus, where in the United States, this adenocarcinoma, or a Barrett esophagus, that's it's called, may be the most common. So in other parts of the world, squamous cell cancer is very common, and that's what's most common in the southeastern part of Africa. And there are belts of squamous cell carcinoma frequency throughout the world. One is in China, one's in Iran, and one is in the southeastern part of Africa. So these are areas of high incidence for squamous cell carcinoma, and areas where we have to be concerned about it. If we can find early cancers, or find cells that are pre-malignant beforehand, that would be great. Like, it'd be nice to do screening like we do screening for breast cancer, we do screening for colon cancer. Throughout the world, it's well known that before one gets cancer of the colon, one has a benign growth that then turns malignant. And the benign growth is a polyp. If we can do colonoscopy and remove the polyps while they're benign, then the patient will not get colon cancer. So it would be nice if we could do the same with esophageal squamous cell carcinoma. If we could do screening for that and find early changes before the cancer develops, that would be terrific. So we're now looking into trying to find screening methods that we can use in countries where there are lots of resources. Like in China, they do screening with endoscopy. We just don't have enough endoscopists or enough endoscopy equipment to do endoscopy screening in Africa. So we're looking for other ways of trying to do screening and early diagnosis.
Right. Thank you so much for for that kind of insight. uh, which leads me to another question. You've talked a lot about, the screening, but what are some of the symptoms that maybe esophageal cancer symptoms that people should look out for, communities should look out for to seek medical care? Because one of the things that you've seen is that many people present late in their cancer diagnosis because, again, we ignore certain things. And in addition to the symptoms, what are some of the causes for the challenges we're seeing with esophageal cancer in this belt, the Southeast Asia? I mean,
Well,
Southeast Africa.
let me address the symptoms first. One of the problems of esophageal squamous cell carcinoma is it's a silent carcinoma.
Mm.
Um, it Nobody knows that it's going to happen, and you only begin to have symptoms when you have difficulty swallowing. That is, if you have, and what happens is patients may have difficulty swallowing meat, and they wash it down with some water, and then it goes away. And then they may have a little more trouble swallowing soft foods, and they don't think anything of that because if they take some water down, the soft food will go down, and then finally they come in with really problem swallowing. They may not be able to swallow their saliva, and it's so obstructive that they have to spit their saliva into a cup because it won't go down. So this is the progression of esophageal carcinoma is so insidious that patients don't come when they first feel the symptom of difficulty swallowing meat, say, but so they come in late, and that's the problem, is when they come in late and they have difficulty swallowing water, or there's difficulty swallowing the saliva, then they come in, and by then the cancer has really progressed quite far. And what we have to do for these patients is to investigate them, make sure that the cancer hasn't spread to other areas, and if it has, we have to put a tube down into the esophagus to open up that passage so they can swallow again. But that's a temporary measure, and it would be nice if we could find the early symptoms before they begin to have really high advanced trouble swallowing. So what are the problems? Well, what causes that? Very difficult to know, but it certainly poor oral hygiene. Um, Dentition is one problem. Alcohol and smoking is another cause for esophageal carcinoma. And of course, oral health. It's some of the work that we have done in Africa has indicated that hot beverages may be a cause for esophageal carcinoma. That is, drinking extremely hot beverages all the time. And maybe one of the most important things is when I was in Uganda, I was quite surprised to see that patients who live in homes, individual houses, have a little house outside, sort of an outhouse in which they cook. So they cook their food outside because they actually heat the food up with a wood burning fire, and they put wood underneath the iron pots, and they heat their food that way, and there's a lot of smoke that comes up, and the some of the men and the women and the kids sort of hang out in these places where they cook. They're not well ventilated, and there's a lot of smoke inside, so women and men and children are exposed to the smoke, which has toxic fumes, that may cause the esophageal cancer. So certainly there are a lot of factors that go into the etiology or the causes for esophageal carcinoma, and there is an organization in this part of Africa called AFREC, um, the Esophageal Cancer Consortium. The AFREC is a group that is composed of doctors and nurses and interested people from that area of Africa, but also throughout the world. And AFREC, the AFREC group, is founded to look into the problem of esophageal carcinoma and what can be done to reduce the burden of illness in this one area of Africa that has a high incidence of carcinoma. So they do research, education, general education. They try to find out what the causes are, what can be done. They do clinical care, research, education, and prevention. So it's a coordinated effort to try to do something about the problem of cancer of esophageal squamous cell carcinoma in this area of Africa.
Right. Thank you so much. And when you were talking, giving us that insight, I thought of what my conversation with someone from Uganda in the government when I was talking about esophageal cancer, and I said that I've heard through the talks that you and your teams and the AFREC team have been giving. One of the causes that is the hard beverages that you mentioned. And that came as a surprise, even to me when I first heard it. It was a bit of a surprise. So my question is, have you come across any specific research regarding that? Because I know very, very many Ugandans who drink a lot of hot tea, myself included.
Yes, actually, the Africa, the African uh, Esophageal Cancer Consortium has done a lot of research, and we've written multiple papers that are in the literature about the causes for it, and hot beverages is certainly one of the causes. Um, that is, they drink beverages hotter than most people can drink beverages. That is 160 degrees Fahrenheit. So they're able to ingest really hot beverages, and that may be a cause for damage to the lining of the esophagus and promote a response of healing, and then abnormal cells are engendered to make up for the damage of the esophagus, and those abnormal cells develop into malignancies and uh, uh, and subsequently grow to obstruct the esophagus. So there are lots of research and studies going on now, and not only how to look at the causes for esophageal cancer, but also try to find out the early damage to the esophagus. So now we're working on looking to do screening for these early changes that we may find. Like I said, in high resource countries, they can use endoscopy to look down, but we are using a certain type of sponge that looks like a vitamin capsule. And it's on a string. Patients swallow the string. The device that's as big as a vitamin capsule goes down into the stomach. acid dissolves an outer coating, and all of a sudden a sponge pops up, which is about an inch in diameter or 2 inches in diameter. And once the coating has been dissolved, the sponge enlarges in the stomach. We pull it back up through the esophagus. It scrapes the walls of the esophagus and collects cells. So when the sponge comes out of the mouth, we put it in certain solutions and get the cells out of it, look at the cells with the microscope and see if there's abnormal cells there, and that can tell us that this patient may have early signs of abnormal cells, and then those patients we can look at with an endoscope and more highly specify the persons that need to be endoscoped and have a diagnosis made of early changes, so that we may be able to extract or cut out those abnormal areas in the esophagus. And we can do that endoscopically now, so that we can treat these early areas of abnormal cells before they turn into cancer.
Right, which brings me to one of the final questions I have. You've talked about these malignancies and the obstruction of the throat, of the esophagus by these tumors. And one of the interventions right now that is happening, thanks to AFREC, is the insertion of stents. Could you please explain what that process is and what those stents are, and how, the purpose, in terms of giving some of these patients relief, and at what stages do it gets inserted?
Sure, Vivian, I'd be glad to talk about stents. Stents are interesting. Everybody knows that when patients get a heart attack, they go to a cardiologist and they are able to put a catheter up into the heart and put stents into the coronary vessels. These stents are very small, but what is a stent? A stent is actually a tube that opens up, and it reestablishes the ability to put something through either a vessel or esophagus or some other place that we can actually put the stent in, and it'll open the passageway. So for us in the esophagus, putting stents in is a big deal. The esophagus may be narrowed. It's very difficult. We may be able to look down and see the cancer, but we may not be able to see a passageway through the cancer. So we then put a tiny little guide wire through, and we wiggle it through the tumor until it gets in the stomach. And then once we put the guide wire in, we take the endoscope out, and then we put a tube over the guide wire so that it goes in the right place, and the guide wire will allow us to put a tube down into the tumor and then through the tumor. And then as we pull this tube back out, we can actually unsheath a stent. And the technology now is so fascinating that the stents that are put in are really very highly coiled, and we can put a stent in about with a sheath smaller than a pencil. So we put the sheath in. As we pull the sheath out, we unsheath the stent, which is a metal tube. And the metal tube is actually a mesh that uncoils as the guide wire as the sheath is pulled out over the guide wire. So we know what the lower end of how far in the lower end of the tumor is. We put the lower part of the sheath beyond the tumor, and then as the sheath is pulled back, the stent expands as we pull the sheath back further and further. The mesh of the tube of the stent actually enlarges and opens up in the passageway that was obstructed before, and then as we pull it further back, the upper end of the sheath extends above the tumor. So now we have a stent that is below the tumor, is above the tumor, and through the tumor, and it gradually, because it's a sort of a crosshatch compressed sheath, it actually has the ability to expand like a spring and expands within the tumor and pushes the tumor aside. And then we leave the patient with this stent that is a wire mesh inside the esophagus that will now give them full passageway, not quite as wide as a normal esophagus, but will allow them to eat food and drink normally. So the stent is quite a remarkable device that's put in while it's very, very compressed and narrow, and then it expands once it's inside the tumor and allows the patient to actually be able to have nourishment, swallow their saliva, and swallow food and liquids so that they're no longer obstructed. It's a remarkable advance, and it's too bad that we have to put these stents in patients that are completely obstructed, but it's a remarkable relief for patients who are not able to swallow anything, and they come in and we can put stents in, use the technology to reestablish a channel through the tumor. It doesn't prolong life, but it certainly makes life acceptable for these patients who are not able to either swallow or have any nourishment.
Right. Of course, I was very impressed by the technique from the day that I got to learn about it. But one of the questions that, people who are not endoscopists or who are not proficient would have is, does this stent require maintenance of some level? It's a foreign object, it's metal, it's inside the body. What is it made of? Yeah, other than metal that will make it, safer for the person. I know that it's inserted really in people who are in late stages of cancer. So oftentimes it's palliative. Yeah, if you have any feedback or answers to those questions, that would be great.
These stents are made of metal, and there's a few different types of metal that are used, but we use stents that are biocompatible. That is, they're metal, but they are made with a great deal of care that patients can also have radiation, even though the stent is there, and it's not going to interfere with the use of radiotherapy or any of the other diagnostic tools that can be used. So they're certainly biocompatible. They will stay there forever. These patients don't tend to live very long. When patients come in obstructed with esophageal cancer, they live for 3 to 6 months. But for those 3 to 6 months, they're able to swallow and can function fairly normally. The one thing is that some patients, if we work them up and do a CT scan and find there is no metastases, the squamous cell carcinomas, some of them may respond to radiation therapy. So we may want to radiate the tumor while the stent is in there, and that will cause the tumor to regress. Sometimes it will cause the patient to go from a stage 4 cancer to a lesser stage cancer, and they can then be operated upon successfully. So the stents may be a bridge to surgery for some patients, and certainly they relieve a lot of really devastating symptoms for patients who present with obstructing esophageal cancer.
Yeah, and what are the trends of using these stents here in the United States, and how can we also extend or increase that service to regions that are under-resourced that might not afford them, given how much we know they cost? Yeah.
Well, one of the problems of stenting in low resource countries is that the stents themselves cost between $1,000 and $2,000.
Mm.
That's a tremendous expense for patients whose annual salaries may not even come to that amount. So fortunately, uh, the AFREC, the African Esophageal Cancer Consortium, has partnered with Boston Scientific in Boston, which is a company that makes a lot of endoscopic equipment and equipment. They make stents for coronary arteries, for urology, and they make stents for intestinal tract. So they have partnered with us to make stents, some stents free and some stents very low cost, so that they have partnered with AFREC to supply stents for patients that just cannot afford stents, and we use their stents to actually open the passageway through these obstructive carcinomas, and some patients pay a minimal fee, and some patients can get them for free. So it's a remarkable advance to be able to have these stents that are so expensive to be really donated by companies. We really need a lot of resources to help patients in these low resource countries in the southeastern part of Africa, where the esophageal cancer is so rampant. We need a lot of resources. We need funds to train doctors. We need funds to buy endoscopes. We need funds to provide stents for them. It's a real problem. And right now, the Olympus Corporation is also trying to supply us with endoscopic equipment, and with the necessary help to develop expertise in using stents, and to allow us to purchase the instruments that are necessary for us to deploy these stents in patients.
Well, which again, great work. Thanks for the service. And I think one of the final question is looking ahead, as we're thinking about the future. How do you envision the role of endoscopy evolving in global health, say over the next 10, 20 years?
Um, I think that we're going to be having a lot of changes right now in the field of say the colon, um, where we're using colonoscopy as a screening procedure to screen patients and find the polyps and take them out. We are now having some blood tests that we can find early evidence of abnormal cells floating throughout the body, because when abnormal cells present, they're right next to the bloodstream, they shed cells into the bloodstream, we can do a blood test and find out that the patient has early signs of abnormalities that we may intervene in. And hopefully we'll be able to do the same thing with endoscopy, with squamous cell carcinoma. We'll be able to take a blood test, find out which patients have these abnormal cells, and go in and do actually biomedical advancing treatments that may prevent the further development of abnormal cells. So I think that endoscopy will be able to help out with targeting these patients. Once the abnormal cells are found, we may be able to inject some sort of solutions that may reverse the abnormal cells. So I think endoscopy is going to have a different approach in the future, but it's always going to be worthwhile and keeping a view of what's happening inside the body.
Excellent. And then maybe just a follow up of that. What are some of the ethical considerations we should keep in mind when introducing, at these advanced procedures in areas that are low resource, that have low resources, that are limited in post-operative or follow-up care, so that we really do not distract life. And as part of that, what policies do you think the governments also should have to prioritize endoscopy and integrate it in the national health systems?
Certainly, the ethical considerations of what we're doing is paramount, that we want to be able to provide high caliber care to patients without harming them. And I think that one of the problems is that we need to have the resources available for providing assistance to patients, but we also need to do it in a way that's feasible, that's worthwhile, that's affordable, and ethical. So we really have to be very careful before we begin doing things like putting a stent in and not having any follow-up for the patient. These patients don't have a normal swallowing function with the stent. They have to be careful of what they eat. Normally, the esophagus has peristalsis, has waves of muscular activity that propel food from the upper esophagus down the lower esophagus and into the stomach. The stent does not have a peristaltic capability. It's just a rigid tube that's there. So patients have to be careful that what they eat and how they eat it, and they have to be taught how to survive, even though they have a stent that gives them free passage into the esophagus. We do have to maintain a relationship with these patients. We can't just put a stent in and send them home and tell them not to worry about it anymore. We have to provide constant supervision. We have to be in contact with them. Once we put a stent in, we certainly have to be sure that the patient has a sufficient investigation, that we know if they have further spread of disease outside the esophagus, or whether they have end-stage disease that no one can operate upon or do anything for them. So we have to be very vigilant in our care of these patients all the time. So we have to be sure that not only do the patients themselves have to be followed up and instructed, but the general population needs to know that this area is a high risk area, that when patients present with trouble swallowing, they need to be seen right away. The government also needs to know that there's resources that have to be provided that we can investigate these patients, and hopefully in the future we'll have widespread screening so that we won't be able to have the patients present at an end stage where they have difficulty swallowing, but we have normal patients that have no symptoms that we can screen, find early evidence of abnormal cells, and treat them before they develop the monstrous carcinoma that is so prevalent in this area.
Well, thank you so much, Jerry, Dr. Way. Thank you for your time, for your insights into the world of endoscopy, for what you're doing in Uganda and other parts of the world. And I think we've kind of covered a large scope of the area. But is there any final word you have for our viewers before we say goodbye?
Yes, I think that we're pleased and happy to participate in this AFRIC and in your uh, broadcasts and blogs. It's a tremendous ability for us to spread knowledge throughout this area. But I think that the important thing is that we are making progress in this field. We have to allow the patients to have access to better medicine, and we need public awareness of what's happening, and we need to spread the word that we can do something about esophageal cancer, that research is ongoing, that we'd like to prevent it if possible, and we need resources to help out. So we need funding for physicians training. We need funding for scopes and equipment, and we need funding from the government that we can use to promote public awareness as well as treatment and therapy for the disease.
Well, again, thank you so much for your time, Dr. Way. I look forward to bringing you back so that we talk more about endoscopy and global health, and as we roll out FREX programs into other countries. I think it'll be great to bring you back and share some of the experiences, even with what you're already doing in Uganda. But for now, thank you again for being a guest on the show.
Thank you, Vivian.
And to our viewers, thank you for watching. Till next time.